Hello, class. Dr. Mike Burford coming to you here again for our psychopathology class, and I want to talk with you today about trauma and stressor-related disorders. And as you know, the PowerPoint is available to you on your D2L site, and from what I understand, it's also being made available on the video here. But if not, you can certainly go to D2L and find it. All right. I want to remind you that the Diagnostic Statistical Manual of Mental Disorders is our reference point. Information for this mini lecture is taken from the DSM-5. Reason for that is because that is what you will be using as a clinician. Your textbook for class has some good information in it. But I doubt that any of you will be carrying your textbook around when you're actually in clinical practice. However, I do hope that when you are in practice that you will own and actively use a DSM-5 in your work, especially in your work as a diagnostician. Okay, so let's have a little bit of an overview of trauma and stressor-related disorders. Diagnosis requires exposure to a stressful or traumatic event. And a close relationship to anxiety disorders and obsessive compulsive disorders, or disorder and related disorders and dissociative disorders exists. And in fact, I remember when trauma and stressor-related disorders, primarily PTSD, post-traumatic stress disorder, was actually listed in the anxiety disorder section of the DSM. So all of that, of course, was changed recently with the advent of, or with the publication of the new DSM-5. But the thing to really remember about trauma and stressor-related disorders is that the diagnosis does require exposure to a stressful or traumatic event. That's the common denominator right there, the common thread that'll run through these types of disorders. Okay, so let's talk about reactive attachment disorder. And one of you recently had made comment about reactive attachment disorder and expressed interest in that. So here's a little information about it. It's a consistent pattern of inhibited, emotionally withdrawn behavior toward an adult caregiver. So, in other words, this would be a minor that has this disorder. And they have a disinterest in seeking comfort when distressed and diminished response to comfort when they are distressed. So, in other words, they don't seek comfort at times of need, and if provided with comfort, they don't respond very well to it. Persistent social and emotional disturbance is a characteristic. There's limited social and emotional responsiveness, limited positive affect, and episodic unexplained negative emotions in the presence of a non-threatening adult. There's a history of extreme or insufficient care. There's usually social neglect or persistent deprivation of basic emotional needs, repeated changes in primary caregivers resulting in inability to form stable attachments, and rearing up in environments that severely limit opportunity to develop attachments. I'm wondering if any of you can think of instances where some of these characteristics may be cultivated. Social neglect and persistent deprivation, repeated changes in primary caregivers, coming up in environments that limit opportunity to develop attachments. For those of you interested in working with kids, you're probably thinking, well, let's see, that may occur in foster care systems and congregate care facilities. And indeed, you'd be correct. I remember in the years that I spent working in those types of environments, several times that kids would be shuffled from home to home for whatever reasons, sometimes despite best efforts of staff and the system itself. It's easy for us, I think, to be upset at the social service system and cast stones and cast blame. I do want to say that a lot of those folks that work in the system do an excellent job working within the confines of the system. And they, a lot of them, realize that the system isn't perfect, and it bothers them every bit as much or more than the average person that's not involved in that kind of work. These people actually live that work day to day, and having been one of them and friends with many of them to this day, I can tell you that sometimes people working in social service systems, such as the Department of Children's Services, get frustrated and scratch their heads as well. A lot of them really do work hard and want the best and care for these kids. But for various reasons, it could be any number of, there's a whole lots of reasons that kids would change facilities, change homes, foster homes, group homes, and that kind of thing. But basically what it all adds up to is just an unstable placement history, which hampers the ability to form attachments. And also in group homes, for instance, if you've got 3 or 4 staff working, 2, 3, 4 staff working a shift, then and you've got 8 kids or 12 kids or whatever what the ratio is these days, staff to client ratio, then it's very reasonable to think that not every kid in that group home is going to get all the attention that they need, because there's so much competition for the attention, for the resource that's there. So now, so we could make the argument that growing up in a foster care system or a congregate care system is a bad thing. And I won't disagree with you there. I think every kid needs a home and somebody to love them and all that. But I can also tell you that I've had several kids over the years who liked it in the group home or the foster home, and if they were sometimes about to be discharged back into their family of origin, would actually act up behaviorally so they didn't have to go. And sometimes they weren't able to articulate their feelings about that. But the ones that were able to say, well, I don't want to go home because it's so much better here, because at least here I get fed and I have some level of security, and I know that somebody's in control of things and watching out for me and providing my needs and getting my health care met and all that. And so some of these kids just really didn't want to go home. So as difficult as the system can be at times, it's also much better at times than environments from which kids have come. But reactive attachment disorder can be perpetuated in such environments under certain circumstances. And that's certainly not to say that every kid would have reactive attachment disorder because they're in a group home. That's not true. In fact, I can tell you that in my years of working in that environment, I've only seen 2 kids who had reactive attachment disorder. I saw several who people claimed had the disorder, but actually had one of the behavioral disorders or some other kind of disorder. So it's pretty rare, this disorder. All right, so let's talk about post-traumatic stress disorder. Now, you hear a lot about that, PTSD. Lots about that with our veterans returning from conflicts and wars over in Iraq and other places. So my guess is that as clinicians, you will probably, at least on occasion, be treating people that have post-traumatic stress disorder. Fortunately, our government is acknowledging that PTSD exists and trying to provide supports for that. Saw something on the news out of the White House just yesterday about that. Okay, so let's talk about this disorder for a minute. With this disorder, there's an exposure to actual or threatened death, serious injury or violence occurring to self or others. Now, of course, when we say death, we're not going to. Obviously, death doesn't apply to the self. I mean, if you've experienced death, you won't be having any kind of disorder. So that goes without saying, I would hope. Anyways, exposure to actual or threatened death, serious injury or violence occurring to self or others. And there's intrusive symptoms associated with and subsequent to the traumatic event, such as recurrent distressing memories and or dreams, dissociative reactions such as flashbacks, intense or prolonged psychological distress at exposure to cues associated with the traumatic event, and strong physiological reactions to cues associated with the traumatic event. Persistent avoidance of stimuli associated with the traumatic event, and negative alterations in cognitions and mood associated with the traumatic event. Such as dissociative amnesia, persistent negative beliefs about self, others, the world, causes and consequences of the traumatic event, fear or anger, guilt, shame, anhedonia, and feeling detached and or estranged. Significant changes in arousal and reactivity associated with the traumatic event would include irritability and angry outbursts, self-destructive behavior, hypervigilance, exaggerated startle response, poor concentration and sleep disturbance. And all of these remind me of actually someone I know who returned from Vietnam, a family member of mine, and he had been in active combat in Vietnam. And at the time, I was too little to remember this, but I was told that in the small community that we lived in, there was a volunteer fire department. And the volunteer fire department would have a siren that would go off, and you could hear it all through the community when there was a fire and the volunteers needed to come and get the equipment to put the fire out. So I was told that one day the fire whistle or fire alarm rang, and my family member was in bed, and out of habit rolled out of bed and rolled back up and under the bed without second thought, and had apparently learned to do that in Vietnam when the rockets would come in and be exploding in and around his camp. I look back at that and some other things that I've heard him say, and I'm fairly well convinced that he has PTSD, and fortunately is getting some help for that now. But also with PTSD, one of the features that you need to be mindful of is that symptoms exist for more than 1 month. Now that's opposed to acute stress disorder, which is very similar to PTSD, except for the duration of symptoms is 3 days to 1 month. The other thing I want to tell you about PTSD is that it could take a while for symptoms to develop. Just because somebody had a traumatic event and they appear to be fine for a brief while afterwards doesn't mean that they haven't been traumatized and that they'll require care later on, or at least benefit from care later on. With adjustment disorders, emotional or behavioral symptoms occur within 3 months of the stressor. There's marked distress that exceeds what would normally be expected from experiencing the stressor and does not represent bereavement. There's impairment in social, education, or occupational functioning. And there are several specifiers with adjustment disorder. And one of the big things that I wanted to say about adjustment disorder is that when considering giving this diagnosis, you always want to make sure that an occurrence of a stressor has happened. You want to be able to identify exactly what it was that caused the distress. And then you want to ask yourself, well, is the level of symptoms that this person is having, is that appropriate for the stressor, or does it exceed what would normally be expected? So right there is your key for this particular disorder. Of course, now we can get further evidence that an adjustment disorder has existed when the stressor goes away, and if it's an ongoing stressor, and the person no longer exhibits symptoms. I mean, that's a pretty good telltale sign that an adjustment disorder has been underway. So there are several specifiers for adjustment disorder, and as you know, a lot of times in my lectures here, I don't go into the specifiers for disorders because they can be quite lengthy and convoluted, and they are laid out fairly well in your DSM. But with adjustment disorder, I feel like it's appropriate to look at some of these. So we'll begin with, as you can see on your slides, 309.0 is the diagnostic code, and that's adjustment disorder with depressed mood. So if a person has an adjustment disorder, they're likely to have either a depressed mood or anxiety, or sometimes both, or sometimes they have problems with their emotions, and for instance, they may have anxiety and or depression and problems with behavior. They may be acting out behaviorally in some way. So as you can see, we've got, let's see, what is it, 3, 4, 5, 6 specifiers. The first one being with depressed mood, and then with anxiety, and then with anxiety and depressed mood, then with disturbance of conduct, and then with mixed disturbance of emotions and conduct, and then finally adjustment disorder unspecified, for when we aren't sure if the other specifier requirements are met. For instance, perhaps we don't have enough information yet. Maybe we suspect that adjustment disorder is there and aren't quite sure what the specifics are in terms of specifiers. Okay, so treatment for these types of disorders would include cognitive behavioral therapy, exposure therapy, eye movement desensitization and reprocessing has shown some promise. One of the things too that I want to tell you about treatment with stressor-related disorders and anxiety disorders and all that is that if you intend on using exposure therapy or some kind of therapy where behaviors are put into place that will cause extinction of the fear response and all that. One of the first things you want to do before you engage in any of that is to make sure that your client has some coping mechanisms and techniques that they can use in case the stress gets really bad for them. And so you don't want to make them worse, obviously, but sometimes in dismantling some of these disorders, things can get pretty stressful for the client. So you want to teach them things like relaxation techniques, maybe mindfulness meditation, maybe Jacobson's progressive relaxation techniques, breathing exercises, those kind of things to help them manage their stress levels as they're undergoing treatment. Okay, so that's a little about trauma and stressor-related disorders. You certainly have enough to read about that in terms of your DSM and your textbook, and then some of the suggested readings too. That should inform you pretty well about these types of disorders. And feel free, if you have questions about any of that, to send me an email, or perhaps even better yet, raise the question on the discussion forums on D2L for our site, and see if your classmates would have thoughts on it. Of course, I'm in there too, so the other thing I want to remind you guys of is that a good clinician is a clinician that's able to get into literature databases, look things up, and learn to search and find information and answers about these disorders, or about treatments for these disorders and all of that. As a practicing clinician, I do that on a regular basis, and in fact, I find that the best clinicians I know tend to do that as well, as opposed to running on secondary secondary information. So the best thing to do is to get in the literature database and learn to use it and become informed. I'm certainly glad to help you as well, but my hope is that you're able to use databases and look at some research articles to find out what the latest and greatest is, and get in the habit of doing that so that when you're in practice, you'll be an informed practitioner that's on top of your game. All right, so have a great week, and I'll plan to see you another time. Take care.